Welcome back, Journal Clubbers. Ed Bowder and Dan Schwester on the Overruns YouTube channel for another Magic Monday. And today we're going to talk about gasping CPR. So this is a study that came out of Japan, which I thought was pretty interesting. And Dan, what we're looking at here is, and this is from Akamoto et al., they looked at it. This is a case series, right? This is just two patients that they looked at, and they looked at these cardiac arrest patients and how extracorporeal CPR might actually help them. So we'll talk about these cases real quick, and then let's get into what eCPR is and whether or not it's the future of EMS or not.
Yeah, sure. Lot of buzz about this being a new technique for rescuing people in cardiac arrest. eCPR is basically ECMO. It's basically putting someone on a heart-lung bypass and oxygenating the blood for them so it gets to their brain and vital organs so they don't have the organ damage and the brain damage and the bad outcomes that we have. There's different ways to do it. It's mostly an in-hospital procedure, although there are some places that actually will do this in the field. It seems to work very well in situations where cardiac arrests are witnessed, where there's bystander CPR, and where you have a persistent VFVT type arrhythmia that's preventing you from reestablishing ROSC. So let's get into the paper.
Absolutely. And something to keep in mind is that this is something that it's fairly new. This paper came out in July of 2022. And again, we always add the caveat, when you've seen one study, you've seen one study, and this is a case study of two patients. So the keys to this study is both of the patients were in a VF arrhythmia, which we'll talk about in a second, but key to this was that both of these patients were gasping. So when EMS got to this patient, they still had some function of their medulla. So the brain was still giving the impulse to actually breathe. So they still had contraction of their diaphragm. They still had activity in their 10th cranial nerve. A lot of times in cardiac arrest, we'll look at the actual cornea. We'll look at the eyes to see if the third cranial nerve is working. And that's one of our first signs for hypoxia. So these are patients who were gasping. They were colloquially what are known as fresh kills. So these patients were very, very recent in cardiac arrest. This first case is a 58-year-old male who had a history of uncontrolled hypertension and hypertrophic cardiomyopathy, which again is something we've seen a lot in the literature. Untreated HOCM is something that is the cause of cardiac arrest. Usually we see it in athletes. We had the Damar Hamlin thing a couple of years ago, and we know that this is a predisposing factor to cardiac arrest. So this patient was found in VF. The patient was asleep. He began groaning while he was sleeping, and that groaning, there's just a very specific type of moan of people who go into cardiac arrest. It's very hard to recreate, but it's one of those things that if you've been to enough arrests, you kind of know what it sounds like. It's almost like, I don't know what C. diff looks like, but I know what it smells like. And in these settings, you have to see, all right, the brainstem is still working, whatever. So they did CPR. They did 5 rounds of epinephrine. Spontaneous circulation did not come back. They still had the patient gasping. So what's not mentioned in this article is what type of CPR was being done. But we do know that during the CPR, the brain was getting oxygenated. So again, we don't know if it was hands-on, if it was a band-driven device, if it was a piston-driven device. But we do know that CPR was circulating blood to the brain. So this patient was down for 67 minutes and was taken to the ER. ECMO was started at time plus 82 after the cardiac arrest. The patient was put on ECMO, had an angiography performed. They found no significant stenosis, which is really interesting. And again, this is a HOCM case, right? So this is someone who wasn't necessarily having the classic infarct that we would see. But this patient was placed on a balloon pump and he was discharged a day plus 38. The balloon pump was taken out on day 5. ECMO was withdrawn on day 4. And this patient had a CPC score of 1, and a year later, his CPC was 1, which is to say a CPC 1 score is Danny and I right now. There's no long-term sequela. And this second patient, a 49-year-old male, complained of back pain. He's initially stable. And this is the nightmare patient that we all think about in EMS, right? You get a sort of benign complaint that eventually evolves. And that's where you get the pucker factor that we've all heard of, right? Again, this patient was in VF. CPR was started. He was put on ECMO 93 minutes after the onset. They did an angiography. They found a left main occlusion. Put in a balloon pump. They did target temperature management, which is something we haven't heard of in a long time. And they moved him up to the ICU. ECMO was taken out again on day 4, balloon pump on day 5, and he was discharged on day 44 with a CPC of 1. So these patients, and again, this is 2 patients, is a very specific type of study, but these were patients that had prolonged CPR. They were put on ECMO. They had a balloon pump placed, and they were coded for a long time, and then they survived to discharge, which is kind of the goal, obviously, of what we're doing. So let's get into what we need to talk about here for the eCPR. So we see these patients, they're fresh arrests, and we know that they're gasping, so we know that their medulla and their brainstem is still intact. I think for a long time, Dan, we've kind of been taught like 20 minutes in and out, boom, done. And it at least colloquially, it's starting to kind of look like maybe that's not best practice, at least in these very specific scenarios.
No, this could be leading to a change in the future. Remember, again, I want to say this is a 2-person case series, but there's some good takeaways from this. First and foremost, these were witnessed cardiac arrests. So the patient collapsed, somebody was there. More importantly, somebody was there immediately to get on the chest and start compressions. So even in that low flow state, damage was minimized because they were keeping some sort of forward blood flow going through manual compressions or whatever happened. When the trained rescuers got on scene, they continued that treatment. They initially initiated ACLS, as we all would. They defibrillated, was attempted, and they got the patient to a place that could perform ECMO. And this is going to be a thing. I think this is going to be an up and coming thing. You're going to see more hospitals become resuscitation centers, cardiac arrest centers, where they're going to have the ability to do this down in the emergency department. And for a certain subset of the population that maybe is just in a refractory VFib VTAC or has an MI and is, we need to take them to the cath lab and we need to fix that to fix the heart. These people do very, very well. It's going to be a challenge, I think, for us to find those patients and select them appropriately. There is one program that I know of in the United States that actually does this in the field. There is one I know in France that does it. The preliminary data, and maybe this is a episode for the future. The numbers seem pretty encouraging. Whether they have CPC 1 or 2 survival, which is very good, either no problems with daily living or just generally need a little bit of assistance to get through their day, as opposed to most people who survive cardiac arrest now in the United States who are pretty debilitated. I think that there is a potential here. I think that we should look at this, but the clinical takeaway from me right now is if I'm 20 minutes into a resuscitation and I'm still getting a shockable rhythm, or I've got good CPR going or mechanical CPR, and I see this patient gasping or doing any kind of reflexive activity, I would continue the resuscitation. That's somebody we can transport. That's somebody that may actually have a good potential outcome, and we need to study this more.
And the VF arrest, the survivable cardiac arrest, right? That's kind of the numbers we're looking at. And this isn't new either. We've looked at nationwide at cardiac arrest numbers. We know that survivability is 8 to 12%, depending on the data set that you actually look at. But in cities like, Seattle, when you look at the Medic One system, they only really count the VF arrests, and their survival to discharge is phenomenally high. So it almost kind of begs the question, should we look at the type of resuscitations that we should be engaging in? And that's not to say, we shouldn't do CPR. Of course that we should. But, this is the difference between the patient who was last seen last night at 10 p.m. and it's now, 2 o'clock in the afternoon. And now we're starting CPR on this patient who expired 14 hours ago. Right. This is when you get to these patients and they, this is I didn't feel well, and then I collapsed, and then, my spouse started CPR or whatever. This is a reinforcement of the need for lay people to know CPR, right? Because again, it's the only thing that saves anybody. But I also want to look at this table on this actual study here, because they talked about the incidence of low flow and no flow states. So again, these 2 patients, 49 and 58 years old, which is interesting because they're not the classic cardiac arrest population that we would think of, right? Typically we think of cardiac arrest as at least over 60. Both these patients were male, which might also factor into some things. It's important to note that both these patients were in VF. Again, we have more than an hour for both these resuscitations. What's exciting in this study is when you see no flow time here, which is no circulation to the brain, no cardiac activity, both of these times are marked as 0. And that's interesting, but it's also very important, which is to say the cerebrum, the actual brain itself, may have been hypoxic in these patients, but it wasn't anoxic. And that's kind of the important thing, right? You're getting some oxygen to them, and that's better than nothing. So we have this low flow time. We also know that these patients were put on a balloon pump and they were given coronary angiography. So they were close to centers that had that type of sort of holistic, comprehensive approach to it. And one patient was HOCM, one patient was an acute myocardial infarction. So when we see these patients, right, you walk up and the patient's like, I just have this really bad intractable back pain and I don't really know what it's from. That's where, when we talk about that high index of clinical suspicion, right, we want to know, all right, well, do you have a history of back pain? Like what kind of, medical problems do you have? And these are patients who they may not be under the care of a physician regularly, right? Like, again, the first case in this scenario was someone who had hypertension and obstructive cardiomyopathy who was not diagnosed. He had not been seen by a physician. So I think that sometimes when we go onto these scenes, it's very easy to think like, back pain, whatever, and certainly in some settings, like, it's back pain. This is a BLS job. I don't need to do anything. And that's when I think in that patient's case, the youth is kind of what came on to me. Right. I have a 49-year-old male who's complaining of intractable back pain, and then he starts to get weaker and weaker. That says something to me. We've talked on the show before, right? We've talked on the show before about clinical gestalt, and that feels like part of it, right? When you're looking at your patient, you want to think, okay, does all of this fit, right? Do I have an 85-year-old female who's complaining of difficulty breathing, who's got a history of COPD and asthma, right? In those patients, like, maybe they have a PE or whatever, but I know that their presentation is consistent with their history, right? This is like in trauma, we talk about pain disproportionate to the exam, right? And this is sort of where that is. So getting that good history on the patient, finding out what actually went on with them, and then knowing what resources you have available to you. It's certainly possible that EMS can do ECMO out in the field. We've seen examples of VV ECMO being done out in the field, which is you just have a small little ECMO machine. You establish bilateral IVs, and the blood runs through the ECMO machine, gets oxygenated, and circulates through. As time goes on, as technology continues to be more miniaturized, a couple of weeks ago, Apple came out with the thinnest iPad ever. And, I feel like it's not that long before we start seeing that type of technology rolling out to ambulances. I mean, think about the first life packs or heart monitors that we used, Danny, that, 20 years ago, we were like, oh, this is the best technology ever. And we were still using paddles. And so I'm excited to see where this can grow, especially in EMS. And if you're out in the field, you need to know where your comprehensive centers are. Can this hospital take a patient who's having an MI? If they need to be put on ECMO, can this hospital take that patient? Or can that hospital send them out to a place that will give them definitive care the way that they really need it? Right. And in the meantime, it's also making this kind of interesting argument that if we have these patients who are able to survive with CPC-1 scores after 84 minutes and 65 minutes of CPR respectively, maybe working a patient for 20 or 25 minutes isn't the right answer. Now, again, this study isn't a diaspora. It's not, necessarily practice or protocol changing, but I think it's something that as an industry and as a profession, we have to start kind of thinking about and talking about.
Yeah, if I want to put a caveat in there. In certain populations, again, really important to remember that
this is not for every cardiac arrest.
Now, this is a success of a system. Again, you had early recognition of cardiac arrest. The patient collapsed. Almost immediately, someone started CPR. They were coached through it, or they did it themselves until first responder units got on scene. EMS gets on scene. They continue the resuscitation, do what we all do as providers. And then the recognition was, okay, here's the situation. This is somebody we can rescue from this situation. Let's get them to a place where this is something that they can do, and this is a resource that's available. They got them to the right place, did it safely. The hospital took over, patient was cannulated, put on a pump, and then they had time to discern what the problem was in the heart. In the end, this person goes home because the system worked. And I think that's what we need to remember. The big clinical takeaway for me is have a very low threshold for starting CPR. If you think they need it, go ahead and start. If they sit up and tell you to stop, then okay, fine. As a EMT first on scene, or a police officer or firefighter, go ahead and start those compressions. You're not going to hurt anybody. And if they tell you to stop, hey, great, that's not a problem. But remember, start CPR, get good CPR. The fundamentals matter here. That's the thing I took from this paper. Not that ECMO works. We know it works. What works is, in these cases, that this patient got immediate CPR and continual compressions all the way through, so there was no point of a no flow time.
No, and that's exactly right. The early and again, it's another confirmation. Early CPR, early defibrillation is what actually works. It's nice to have these big fancy tools, right? And there's certainly funding and grants that you can get for all these big expensive things. And there's grant funding, and you can get scholarships, and places will give you these fancy toys. But in the end, we know that resuscitation is basically just trying to perfuse the brain. So you can get into just doing good CPR, and there's different debates about heads up CPR and like that. But good CPR has been proven to improve outcomes and save lives. And this isn't even talking about CPR induced consciousness, which is a whole other type of segment of the population, where you compress enough to perfuse their actual brain, and the patient gains consciousness during CPR. So in this very specific
it's a whole other thing.
That's a whole other, it's terrifying to see, by the way. But in this very specific subset of the population, when you get into a cardiac arrest, and you see that they still have some kind of brainstem activity, and that's what we're trying to focus on, right? If someone is in cardiac arrest, I don't really care whether or not they have frontal lobe function, if they can do math at that particular moment. I'm concerned about actually getting them to breathe and stay alive. And to do that, we have to keep the brainstem alive. The only way we can do that is by doing CPR. I would have preferred that this study showed us what type of CPR was done. I like to think it's high performance team driven CPR. It does not tell us about the handoff at the hospital, which, given the way the paper is written, makes it seem like it was a very smooth turnover at the hospital.
Yeah.
It seems like the receiving hospital knew what to do. They probably had a decent report. This system in Japan is not the kind of system that we operate in, so I'm sure that there are a lot of sort of inroads to make this a little bit easier for everybody. But these are two scenarios where, and again, it's two scenarios, but it is two scenarios that shows that if you have an EMS system that can perform at least decent, let's say decent, right? You have a populace and an EMS population, EMS service corps, that can do decent CPR, right? Have that circulation to the brain. And then once EMS is done, when they crossed over that magic threshold into the hospital that we talk about all the time, right? The hospital was actually ready to receive them and work on this patient. Where in a lot of settings, certainly in the United States, the systems are so fractured and fractionated that you have to call one person who has to call one person who has to call one person who has to call one person before you're actually ready to receive the patient. And in those types of settings, whether it's a spoken hub type of system, or if you set up a system where you're getting reports from EMS, there's a lot of communication breakdown that can happen in that process, right? So this is where you have to talk to your administrators, you have to talk to your system leaders and say, listen, these specific examples show an actual tangible difference that we can make in the field. And whether it's addressing how we get out to do CPR, you could do a public service initiative where you teach lay people how to do CPR, because it's not hard. We've talked about, Columbia Press, or NYP Press rather, has a playlist on Spotify that you can do CPR to. It's something that when we do, public information campaigns, we want to get this type of story out, right? If you do CPR, you can actually fix and save someone's life. Here's the proof, right? Here's the evidence behind it. And I think getting that information out to people and showing that there's some sort of quantifiable evidence behind it is really only going to serve to help. So, Danny, what's your final takeaway from this? Because again, I'm not convinced that this is practice changing, but I do think it's a conversation we need to have.
I agree. I agree that we need to start having the discussion and start understanding what our capabilities are in the hospital and pre-hospital. And in the end, just do it. If you think somebody needs CPR or you see somebody collapse, just do it. It has a better chance. They have the best chance of an outcome right there with your own two hands.
And I think that's perfectly right. And if you're doing CPR on someone and they ask you to stop, you can probably stop then too. Please stop doing that. But if someone is in cardiac arrest and you start to do CPR, you cannot hurt them. The alternative to not doing CPR is that the patient will stay dead. So if there's nothing else that you guys get from this journal club, if you see someone in cardiac arrest, start doing CPR. Early CPR, early defibrillation is what saves lives in cardiac arrest. This fancy stuff with ECMO and all that can help save lives later on, but neither of these patients would be alive today if they didn't receive early bystander CPR. And if we're not going to take away stuff about using ECMO in the field, we should at least take away that early CPR is what actually makes a difference. Let us know what you guys think. Go ahead and read the study. It's attached down in the show notes. And for the Overrun on YouTube, I'm Ed Bowder.
And I'm Dan Schwester.
And we'll talk to you all next week, Journal Clubbers.
See you later.